And I want to just take a moment and welcome you all to the National Consortium of Telehealth Resource Centers webinar series. We are excited that you could join us this afternoon. Just a little bit of information here really quickly. The webinar that you're going to be seeing today and participating in is going to be recorded. We are going to have all of your questions go through our Q&A box. So if you can just touch your screen or click on your screen, you'll see the Q&A. That is where you can drop your questions in. We will be doing all of our questions and answers at the conclusion of the presentation today. Pardon me. I'd like to introduce our presenter today. We are super excited to have Marie Lee with us. She is a virtual care consultant with Henry Ford Health System. She helps deploy telehealth programs throughout the health system at Henry Ford. She started her career there in 2007 as a training coordinator for the contact center and the centralized appointment scheduling hub, which provides for over 600 of the system's providers. Marie was part of a project team to roll out the system electronic medical records. They're using Epic, and the project scope of 3 years and $300 million. So Marie joined the virtual care team in 2017, and she was able to utilize her project management, training, and telecommunications background to implement the new program. She's a part-time faculty lecturer at Eastern Michigan University in the College of Technology. She has a Bachelor of Science in Communications Technology from Eastern Michigan University and a Master's of Education and Instructional Technology. That was a tongue twister for me there.
It was.
From Wayne State University. She also is a certified project management professional. We are super excited to have Marie with us. Please give her your attention. She's going to share some amazing information with you. And just one more slide, if you would, please, Ray. Thank you so much. I'm going to encourage each of you to fill out the post-webinar survey. That's super important for us to know and get some feedback from you guys. We want to make sure that the materials provided and the method it's provided are doing justice to the presenters. Again, the webinar is being recorded, and once it is edited, you will be able to find it on the youtube.com/c/NCTRC site. So without further ado, just a big welcome to Marie Lee, and thank you, Marie, for being with us today.
Thank you very much for having me and giving me the opportunity to present. So this is really exciting. I'm going to talk today about series-based care and how telemedicine or virtual care can be used in series-based care. So a little bit outside of maybe what people would think about as the traditional telemedicine or virtual care programs. But first, of course, a little bit of the demographics where I come from. So I work at Henry Ford Health System. We're a large health system located in southeastern Michigan, primarily in a tri-county area, kind of right around the Detroit metropolitan area, but also kind of mid-lower part of the state. We're also part of Jackson. So we have 5 acute medical surgical hospitals, 2 behavioral health hospitals, 48 medical centers, over 30,000 employees, 12,000 physicians and scientists in a medical group, and a lot of things that fall under that Henry Ford Health System umbrella, including an insurance arm, Health Alliance Plan. Again, we are an Epic EMR shop. So for those of you who are also on Epic, the release that we're on is Epic May 2019, which is not super important for a lot of things, but when we're talking about certain applications, especially in virtual care, sometimes that does become important. Not to the programs I'm going to talk about today, but certainly on other virtual care programs and the flexibility and the things that you can do as part of those software releases. So I am part of a virtual care team. We are actually our own department. We're a department of 7 servicing the entire health system. And we have we have found that there's a lot of coordination and effort that goes into obviously delivering the programs to the different medical areas. So our mission statement is really evolving innovative care delivery to enhance health and wellness through accessible technology that drives connection and collaboration where, when, and how it's needed most. We found out very early on that doctor plus technology does not equal virtual care. It's really about the experience, but really those people, processes, and technology, and the engagement of not only the medical team, but the administrative team that brings all this together. And of course, we've got to engage patients as well. I want to talk a little bit about redesigning care pathways, especially, again, the focus here today is on series-based care. So in OB, how can we use virtual technology to work with those low-risk pregnant moms? How do we look at ways that we can do therapy? And this isn't the traditional behavioral health therapy, this is really caregiver-based therapy training to our parents and eliminate some of those barriers to care that they might have, especially in coming back again and again for, again, series-based care. And then how do you really increase that participation, make sure that they're compliant with their care series, and how does that technology help, and how can we make sure that people are able to access that care? I love this. I love this picture of the Jetsons. So the Jetsons, this is from 1962, and this was how they envisioned futuristic healthcare. So they really had a view into the future here, and it's interesting that even the TV screen that's on the screen there looks almost like a smartphone or a tablet. So this is how it was envisioned by some great visionary in 1962 drawing the Jetsons, and this is what it looks like today. It's not really that different, but in the palm of your hand, in that smartphone that you have, you can see the provider and conduct a video visit. So again, it's not, you can't do everything over video, but there's a lot of things certainly that you can do, especially when the provider doesn't specifically need to have hands on the patient. So we accomplish the video visits through our electronic medical record system. The patients access it through MyChart, which is again part of Epic, and they have a patient portal. The video connection is facilitated through a third-party vendor called Video, V-I-D-Y-O. And so it's a secure platform that kind of runs in the background. So the patient connects through MyChart, the provider connects through Epic. MyChart video visits are HIPAA compliant. And again, we want it to be as user-friendly and as accessible as possible. And in this series-based care, as we were thinking about ways that we can help patients be compliant with their care, this was a very easy way and relatively accessible way, because a lot of our patients, most of our patients, have access to either a smartphone or some sort of device that will allow them to connect via video. Thinking about the two programs as well, obviously there's a lot of discussion about technology and who wants to access it, and is there a concern with older folks? In this case, we're talking about people who could be pregnant and people who are parents or caregivers of smaller, in most cases, smaller children. So the demographic is a little bit more compact in these programs. So the programs that we're highlighting today, again, for these virtual care options are applied behavior analysis for caregivers of children with autism, and we're going to talk a little bit about prenatal care. So starting with the Autism Spectrum Disorder, statistically, 1 in every 59 children has been identified with autism. They're somewhere on the scale. Parents of these children can definitely benefit from some sort of basically coping or therapy sessions. And in evidence-based treatment, we found that the applied behavior analysis works really well with children, adolescents, and even adults with some form of autism. These things are not something, though, that can be dumped on a parent or a caregiver in one session. These are principles that are applied and learned over a series of visits where they can basically learn a skill, apply the skill, see how it changes, increases the child's functioning skills, or reducing the disruptive behaviors they might have in the home, and then, again, work on the next thing. So this training, again, typically offered over a series of sessions, but traditionally it's been in a provider's clinical office, which poses a lot of challenges. One is that if you're bringing the child with you, a lot of times the therapist wants to work separately with the parent and not necessarily with the child right there. So that's one challenge. Obviously, transportation, possibly mobility issues, depending on how disabled the child might be. Certainly the time involved in traveling from clinic to clinic. Oftentimes there's other siblings that are involved, and so now what do you do with them while you're going to these visits? And really the biggest disruptor is a lot of times for children with autism, they're very routine focused, and when you take them out of their routine or out of their environment, they tend to get more agitated. So a doctor's office or a clinician's office is not necessarily the ideal location to practice some of these new skills. But if we can keep a child in their home or their comfortable environment, sometimes it's easier, actually often it's easier for them to go ahead and apply those skills. And just in general, there's a lack of available BCBAs or board certified behavior analysts, especially as we get into rural areas. Now again, Henry Ford Health System is in a pretty metropolitan area. We do, however, serve patients who are further out of that area, and certainly in the Upper Peninsula of Michigan, where one of the children or one of the focuses of our BCBA patients comes from. So he had very specific needs. He would travel, the family would travel to Detroit. It's about a 9-hour drive from Escanaba in the Upper Peninsula. And again, the child had very specific medical needs and would come down for very specialized services, but then they would try to fit in a therapy session while they were here. But they wanted, again, to get the best benefit, they wanted to be able to see the parent multiple times. And coming down multiple times when you live 9 hours one direction is not particularly useful. So they were one of our first patients in the program. And the mom was able to reduce the disruptive behaviors. This was a child who was 16, and he got physically violent with his parents and other siblings in the house. By being able to observe what was happening, the therapist was able to give mom, in this case, some very specific coping skills and opportunities to try different things to really reduce that disruptive behavior. They were almost at the point where the child was going to have to be institutionalized. And through the sessions, they were able to reduce the disruptive behaviors, and the child was able to safely stay in the home. So the Autism Caregiver video visit training, what we were able to do then is enable those BCBAs to provide this service via video. They could keep the patient and the parent in the home, reducing that travel, reducing the stress on the child, and offer it in a very cost-effective manner, and functionally do home visits with these patients without the BCBA having to travel to a patient's home, so reducing the provider windshield time and certainly making it much more convenient for the parent and the child to be able to participate. So kind of changing gears completely, but again, series-based care. Looking at normal pregnancies, as we've worked with our providers, they say that really normal, we want to see a pregnant mom between 10 and 15 times prior to giving birth. If you think about those folks who are pregnant, though, a lot of times they might be working or they might have other small children at home. They want to save up their time off for when they actually have the baby, and they don't want to take additional time off in advance if they don't have to. Again, time, travel, parking, all of those things that can be barriers to care, or in this case, maybe just an inconvenience. If there's a different way to do this so that the temptation to skip an appointment isn't there, especially when things seem to be going well, then we wanted to take a look at what that opportunity might be. So we brainstormed with our midwives who wanted to facilitate this program via video, and we talked about what are the ways in which we can safely care for patients and not have to physically have them in the office. Again, when those pregnant moms are coming into the office, a lot of times it's the time in the waiting room, waiting to get roomed, getting those vitals taken, waiting for the provider, looking at the provider, doing the quick check of the fetal heartbeat. How are you feeling? I'm feeling great. It's 5 minutes that you're in front of the provider, and now you've spent all this time around that for that 5 minutes. So again, how can we safely do this? So we talked about different ways that we could do that would really increase patient satisfaction and improve the experience in that care continuum over that course of care and those 10 to 15 visits. So what we looked at an opportunity for, again, identifying patients who were low risk. So single fetal, definitely not twins or triplets, low risk for the moms, again, falling into essentially a clinical category where we felt that they were low risk. What we would do, in addition to the video visit that they can access through MyChart, is that the midwives would also, at those OB intake appointments, equip the mom with a fetal Doppler and a blood pressure cuff, so that when they went home, every other visit could be done over video. So we're not eliminating the in-office visits, we're eliminating half of the in-office visits. And again, to make sure that we're still ensuring that the mom is safe and that the baby is safe, mom takes her weight and her blood pressure before getting on the video, connects to the provider via video, and then while the mom is on the video with the midwife, can actually use the Doppler, the fetal Doppler, to get that fetal heart rate. And again, at that point, they can discuss any concerns, any issues, any changes. Certainly, if there's anything concerning, the provider at that point would bring mom in and say, gosh, I really want to see you in the office. I'm concerned about X, Y, and Z. Or if things are continuing as normal, then certainly I'll see you at your next in-office appointment, and then we'll continue on this cadence until you give birth. We have had probably somewhere in the neighborhood of 40 moms take advantage of this since the program inception in about October of 2017. And actually, one of our first patients happened to be my partner on the virtual care team. She just so happened to be pregnant at the right time as we were kicking off the project. She swears that she did it just for us, which is awesome. And so from that perspective, not only did I have somebody who was on the virtual care team that knew about the technology and was comfortable with the technology, but from a patient standpoint, she was able to give us really immediate feedback as to what was working, what was not working, and what additional support that a mom going home might need as she's utilizing these tools. Our web, or our marketing department, also highlighted some of the program, or some of the program participants that happened to be employees. And it was really interesting. As we were looking at some of the initial patients in the program, we were finding that we were seeing a lot of internal employees and or employee spouses that were taking advantage of this. So I think it was spreading a little bit word of mouth. And so what we're trying to do is also get those stories out to the public so that more people are aware that this is a care option. So I did include the website link to a couple of the different stories that are available, but this was just, I took a clip of the first couple paragraphs of the story. So Latricia Miles is one of our directors here at Henry Ford, and clearly you can see working mom, multiple children, and she was able to take part in this program as well. And one of the things that they talk about a little bit later in the story is that the whole family was able to kind of partake in her prenatal visits because she was doing them from home. And so as she was listening to the fetal heart rate, her other children were interested and kind of took part in that as well. So it was just a really neat story. And there's a couple of different stories that we have about folks who have gone through this program and how it was very convenient and offered some really unique opportunities for either their other children or their spouse or significant other to take part in that as they were going through their pregnancy journey. In both of these cases, and in a lot of, and again, in all of our virtual care where we're doing live synchronous video visits with a patient, We're equipping providers with pretty simple but standard equipment. It's either a laptop or a computer with a web camera and a sound bar, and it's nothing real special. I mean, it's pretty low cost, but high quality. The video platforms we're using is secure and allows us to do that real-time audio and video connection. And one of the things that as we do our implementations, we want to make sure that we do a workflow dress rehearsal to determine, does all of our equipment work? Do we have a good internet connection at the locations that we're performing these visits from? Obviously, there's always that wild card of the patient end. We can't control what the patient or how the patient's connecting. But to the best of our ability, we want to go ahead and test the technology from end to end. And then obviously training the providers not only on the technology, but some of the real basics of troubleshooting. And it's not really much beyond the did you turn it off and turn it back on again when things aren't working. But we wanted to make sure that the providers had some level of comfort, not only with using the technology, but doing, again, that basic troubleshooting. And then also understanding that the technology is a little bit different than working with somebody face to face. And things just as simple as, where is the patient's eyes? How do you make eye contact over video? So those are just some of the things that we wanted to make sure we worked with our providers on. On the patient side, we also needed to educate the patients. So the MyChart mobile app allows patients access to a lot of their health information, upcoming appointments and lab results, and all kinds of things that are in their medical chart. The video portion is not necessarily something that all patients would know how to use. So we wanted to make sure that, first of all, that they downloaded the app if they were using a mobile device, because patients could access their other information by going through a web browser instead of the app. But the app is kind of the easier access, and it's the only access for video. So that was a really important distinction for us, to make sure that patients had the app downloaded. We definitely needed to educate the staff on how to schedule video visits and when video visits would be appropriate for a patient. A lot of times this was provider driven, and the provider would sort of say, hey, yes, this patient is appropriate for video visits. Go ahead to the front desk and schedule that. It's a little bit different of a process in Epic from a regular visit, but not drastically different. So we wanted to make sure that those front desk and those scheduling administrative folks knew how to do that. From a frequently asked questions standpoint, we wanted to make sure that we had that frequently asked question page updated, and we try to get in as much information as we can while still keeping it simple. But again, any questions or technical issues that might come up or that we've encountered fairly frequently, we try to include in those FAQs. And then, of course, the continuous improvement portion. We want to make adjustments to the program, to the communication, to the training, to the brochures, to the FAQs, anything that is patient-facing. We try to adjust based on feedback that we've gotten over the course of these program implementations, and make sure that, again, patients have what they need, they're able to connect, because we don't want the technology to be a disruption. And then as we've had lessons learned from the providers, same thing, we want to make sure that we're tweaking all of our communication and our process so that it's as seamless as possible, the care can be delivered, and the technology doesn't become a barrier. So I have a video that, as we tested prior to everybody getting online, the audio will not play. I'm going to play through just a little bit of it to show you that this is an example of what we do for patient instructions. I'll let it play a little bit and show you kind of how the connection is. You'll see the video, you just won't hear the audio. But certainly if you're interested in this YouTube video, it is available. The link again is here if you'd like to go out to YouTube and take a look at that. So this is just about a 2-minute instructional video. It gets sent out with the patient appointment reminders in that patient portal. So they have the opportunity to click on the link and to be able to view this video in advance of their video visit. So again, it talks about downloading the app. It talks about that your mobile device should have audio and video. And then it kind of goes through what it looks like in the app, where to click, and how to start that visit. So again, they're able to click on the visit. Once they click on begin visit, it activates their camera, and then once the provider connects, then you'll see the provider. So the bubbles on top is the virtual waiting room. These are your controls while you're in the video visit. The camera icon actually allows you to rotate to your front-facing camera if you needed to show the provider something other than your face. And then once you're connected, that's what it looks like on the screen. I'm going to go ahead and pause that. So again, the video just is that 2-minute instruction. It has some voiceover that talks you through the whole process and what to do, how to connect, how to reconnect if needed, and how to disconnect at the end. So let me get out of this. So the outcomes of the program, so clinical outcomes obviously are sort of the big deal. Providers, when they think about doing care in a non-traditional way, they want to make sure that they are still able to deliver quality care in this alternate method. So when we look at the ABA for caregivers, patients and caregivers in those therapy programs showed marked improvement, and they were able to demonstrate that progress from session to session, and those providers were documenting that progress. One of the big things, though, it's interesting because we say, oh, they had great outcomes, but the reality is, in some of these cases, those caregivers would not have come and gotten the therapy if this wasn't an option. So it's hard to do a comparison, especially in this therapy instance, especially when we're talking about patients who live 9 hours away, because there would have been no comparison. So compared to nothing, of course, it's great care. But again, more research, and I know a lot of folks are looking into doing the research. If we can keep those patients in their home, and parents are able to actually utilize those skills immediately and apply it in that home environment, that has been proven to be incredibly beneficial. And again, in those cases, that again, they would not have done it otherwise. So there really wasn't truly an in-clinic option. In the programs that I just talked about, billing, I don't want to say isn't a concern, but it kind of isn't, because in this case with the OB visits, every other OB visit, it's really, in our world, it's billed as part of a bundle of care instead of an individual occurrence. And then from a telemedicine standpoint, the BCBAs are not approved telemedicine providers. So the therapy sessions in this case were either billed as patient pay, so more of a retail service, or there was some special grant programs or grant funded programs that were being used to pay for the care. So in both of these cases, we really weren't worried too much about reimbursement and what the insurance companies were going to pay for these services, because again, it was either bundled care or it's been patient pay or pay over a grant. This is kind of obvious, but of course the benefits for our patients, our caregivers, and our providers. From a patient standpoint, this is radical convenience. They do not have to physically leave where they are to go get care. And obviously it reduces the time off work. It eliminates those travel barriers. We don't have to worry about how do we cover the other children caregiving at home. And my favorite, especially this time of year, cold and flu season, you can avoid those general waiting rooms where there might be other people with germs. Again, if I'm coming into an office visit and I'm not sick, but now I'm exposed to other sick people. And again, if you're bringing small children, if you're pregnant, those are things you definitely want to avoid. So avoiding the waiting rooms is a big benefit for a lot of our patients. From a provider standpoint, what's in it for them? Well, providers are pretty happy when you're not a no-show. They've held time on their schedule to see you. There's this series of care that they would like you to comply with so that they can get you to that end goal. And in this case, if video helps provide that compliance, then that is something that's definitely a patient or a provider satisfaction. Obviously, we want to be able to reach patients who otherwise would have been unable to participate in the care. And if we can, as a health system, increase access to care, then obviously that is a growth initiative for us, and we can functionally enlarge the footprint of our organization. So instead of just seeing patients in a specific demographic area, now we can really spread that out throughout the entire state. Keys to success. Absolutely, it is essential for technology to work seamlessly for both the patient and the provider. Technology should not be a new barrier to care. Just because we've eliminated some barriers, we don't want technology to become the barrier. And once we get over that initial connection, once we press that connect to video button, the visit should be just as if we're sitting face to face in the same exam room or the same clinical office doing therapy. We want to make sure that technology facilitates the visit and is not a barrier. Providing education and support services to both providers and patients was critical. I think as an internal department who serves internal clients, it's sometimes easy to just focus on the provider and what the provider needs and say, oh, it's the department to figure out how to serve or how to educate their patients. But the reality is, from a virtual care standpoint, we need to look at the whole picture and understand how do we facilitate the patient getting access to that same technology and that video platform and getting connected to that provider in a virtual waiting room or a virtual exam room, I should say, and having that connection. So we want to make sure that we're giving that exceptional experience and comfort with the technology to both our patients and providers. Certainly not everybody is tech savvy. Again, this is a pretty user-friendly technology and interface, but that initial connection can sometimes be a little bit intimidating, and we want to make sure that that works and that people are comfortable with that. The other very interesting thing about virtual care and delivering care over video is that those people skills are really, really essential for maintaining that patient-provider experience. One of the big concerns that we've heard a lot from providers is that they're unwilling or unsure about giving up that personal connection. They feel like if the patient is over video, that somehow they've lost that personal connection to the patient. And so it's really just shifting the mindset of, well, no, you can't reach out and touch them. No, you can't give them a hug if they're your regular patient that you normally do that with. But you're giving them your undivided attention over video. Once you get that comfort level with talking to a camera and realizing you're actually making eye contact with a patient over video, the patient gets a sense that, wow, this provider is really talking to just me. This is time that I'm spending one-on-one, whereas in a clinical situation, sometimes there's interruptions or there's other people. You hear other exam rooms. You know that the provider's got to probably run off to another room. So the video visits almost take on this different feel if the provider does it right and understands that, again, making that connection can still be real and it can still be that one-on-one connection with a patient over video. There are a lot of lessons learned, of course, and that I guess one is that when we look at different programs that can be offered via virtual care, a video is sometimes an option that allows patients to access care that they would have skipped otherwise. They just absolutely would have been unable to do this. They would have, again, either opted for, I don't know, looking online at YouTube videos or something, but not physically coming in if that was their only option. In the ABA, or the autism specific example, the providers found that having a view into the patient home and the environment was incredibly helpful in creating a therapy plan specific to that individual child. And again, the parent able to just kind of show the video of the home environment, maybe the child's room, maybe, where they eat, where they interact, where they hang out with the family. All of those things were really helpful in getting that big picture of not just this child with autism and this parent who maybe is frustrated, but really that bigger picture of the family and the environment and where they're living. And in both of these cases, or both of these use cases, the providers found that talking a little bit during that first in-person session about the technology and how that connection will happen, and making sure that the patient had the app downloaded to their device, and in the case of the OB visits, making sure that the patients were really comfortable or had a comfort level with using the fetal Doppler. Those were kind of that initial, like, let's put our hands on it session was really important, and focus more on the technology in that first visit, or when they have them in the office one-on-one. And then that way, each subsequent visit, the technology again becomes just a facilitator for that visit instead of a barrier or a focus of the visit. Support and training of the providers, absolutely important. And we talked about this already a little bit. People skills, absolutely essential for maintaining that provider-patient experience, even when we're using technology and not face-to-face in a traditional sense. Providers really do need to practice that connection and realizing again where the patient's eyes are, and making sure that the video that they're looking at and the camera are very close together. We do provide online refresher training, so we have an e-learning that can be accessed at any time. And so that's really helpful for a lot of our providers, especially if for some reason they haven't done a video visit in a while. Maybe they didn't have appropriate patients for a while, but all of a sudden they do. They can refresh themselves with that e-learning. And then as a team, as a virtual care team, we do actually periodic check-ins with our programs to determine how's it going. Do they have any additional needs? Do they need more training? Do they need additional equipment? Are they looking to maybe expand their services? Are there things that need to be tweaked, or is there additional messaging maybe that we can provide for the patients of the program? So we do those check-ins as well, and we've found that that's pretty important to our ongoing satisfaction, both internally and then with our patients as well. Obstacles and barriers. I think this really applies across most virtual care programs, and probably is true for anybody who's providing virtual care, but obviously resources for growth and scale. In our case, we're a small but mighty team, but we have a lot of programs that are interested in doing virtual care, but we can't address all of them at the same time. We really need to prioritize and be able to do it in a sane manner, and make sure that people are on the same page, and that they have a good plan for rolling it out and communicating with their particular patients. Providers have to have a good feel for workflow and clinical workflow, and does it translate to a virtual environment? In some cases, again, some use cases maybe will never be appropriate for virtual care, but the ones that are, we want to make sure that they're looking at things that are patient-centered, that offer patient convenience, and then in whatever way possible, if there's ways in which they can reduce sort of their downtime, if they can minimize the amount of time that they're driving, their windshield time, and then looking at what is their incentive, I guess, to adopt. Change is hard for folks, and so, sometimes a pilot program is great, but then if we want to go bigger, what does that do to the provider and the provider's schedule and the provider's stress level? So those are always challenges as well. Patient adoption, just because we've built it does not mean they will come. So how do we communicate that this is good medicine? How do we communicate that this is a good opportunity for them to do something alternative than coming into a clinic? And is it something they would be interested in? And again, making sure that they're confident that this is still good care, that they're connected and they're communicating with their provider, and that they're not somehow missing out on good care because they're doing it over video. The biggest issues, I think, are that the technology has really allowed us to do a lot of things, but things like medical licensure and reimbursement and insurance coverage, those things have not really caught up yet. And so those are always a big tangled web of stuff that needs to be handled. And you know, it's just because we do service patients. We're very close to the border of Ohio. We're very close to the border of Canada. And so just because we're close and we service those patients, virtual care is not necessarily an option, because if they are across a state line and our providers are not licensed in that state, it's not care that we can legally provide. So again, some of those things are being addressed with the compacts and things like that, but always a concern and always a barrier that we have to look at as we're rolling out these programs. And then last but not least, of course, is technology. One of the big barriers, or I guess concerns that we have, is really the browser compatibility with our video platform. Right now, our video platform likes to work with Internet Explorer and Google Chrome. It does not like to work with Safari. And so our users who want to connect on a Mac computer, for example, are currently unable to do that because video and Epic and Mac computers don't play well with each other. And what we found is that on Windows 10, and everybody has now Microsoft Edge, that dark blue E looks very similar to that light blue curvier E of Internet Explorer. And so those are just some of the really basic challenges. Just browsers can be a downfall and a barrier to getting that patient connected. So again, those are all things that we want to be really clear in our communications with, and making sure that we have support for our patients. So virtual care enables us to offer better and connected access to healthcare. Patients more and more are doing things online. They've got apps for that. They want to order that online. So we want to meet those patient expectations in healthcare to do it online and to have an app for that. And of course, that reduces our costs in terms of time and travel, and making things much more convenient for us as patients and consumers of healthcare. And then what's in it for the provider? Of course, we want to increase the clinician efficiency. Real-time audio and video does not necessarily gain a clinician a lot of efficiency, maybe a little bit in terms of you take out the time that the patient is being roomed, and that maybe a nurse or a medical assistant is working with them, so that the patient and provider can get connected more instantaneously. And maybe we gain some efficiencies in other areas of virtual care. But certainly if we can increase compliance with care, again, that is increasing our provider satisfaction. It's making their life easier. In some cases, it's reducing their drive time because they're not going from site to site, or maybe doing a visit out to a patient. So we're really trying to connect those customers where, when, and how they want to be reached. And our Henry Ford Health System tagline is all for you. So I'm going to pause here and see if any questions came in, and I'll turn it over to Dina to kind of facilitate that.
Thanks, Marie. You shared some really great information with us. I do not see any questions in the box. However, I do have a couple.
Okay.
So while folks are kind of gathering their thoughts about what you just shared, first of all, I just want to say the story that you shared about the patient with autism that was able to remain in the home, that was such an impactful story for me. I actually have some family who work with folks on the spectrum, and that's such an empowering information that you were able to share. So thank you for that. Really quickly, can you share what the cost per provider to enable the ability to do virtual care is?
Yeah, you know, it's interesting. Over the years, technology costs have really come down. And so for our providers who have laptops, most of the laptops that we order, or that are standard for our health system, actually have an embedded microphone and camera already. So I'm actually using one of the laptops. It just happens to be the machine that I was assigned. I think they're right around $1,000, but again, it's part of what I get as an employee. It's how I do my job. So there's really no additional equipment that was needed for providers who actually use a laptop. For those providers who are using a desktop, we've we've kind of gone on a couple of standards. We either go with a web camera and a speaker bar, and together those cost about $130. So the web camera is about $100 that we use, or we've gone to what's called a teleconferencing monitor. So it's an all-in-one, and we do a lot of HP is kind of where we're buying a lot of our equipment. So the HP monitor is somewhere in the neighborhood of $230, and it includes, again, the embedded web camera and the embedded speaker so that providers can do those visits. It's not terribly cost prohibitive per provider.
Thank you. That's helpful. And then as an IT individual, do you help patients navigate the challenges that they face, or how exactly do you guys go about like wrapping your arms around patients to give them the most secure sense of doing a virtual visit?
Yeah, that's a great question. So we have, again, where I started my career was in the contact center. So again, that patient call center area, and there's a group specifically within that call center that works with patients who have questions about MyChart. So again, MyChart is that patient portal for our electronic medical record system, and it does more than the video visits. So that group specifically is there to answer questions and to help guide patients through any issues that they might have with MyChart. And over time, as we've rolled out different programs and video visits, we've actually given them specific training on how to walk patients through downloading the app, how to get connected to the video visit. We've given them a troubleshooting guide of things that we run into or frequent technology challenges that people have run into either via user error or maybe a Wi-Fi connection, basically different things that we've run into. We try to give them information so that they can be our point of contact. Again, we have a really small team, and it would be difficult for us to support everybody. So the very technical things, we want to make sure that it's going through that patient access, our 1-800 number for Henry Ford Health System, and they staff that from 6:30 a.m. to 8 p.m. Monday through Friday, and then they have some Saturday hours as well. And then from a provider standpoint, any real technology issues that they have, their first line of defense should be our regular computer help desk or our support desk. But of course, they sometimes will call our team directly. And we do have a few programs that are 100% virtual. And those programs tend to call us first before they call our service desk. But again, we try to help those providers as much as possible, especially on those programs where it's 100% virtual and they're only seeing patients via video.
Very good. Thank you so much. So we actually have had a couple of questions drop.
Great.
So I'm going to read the first one that came in and who it's from. So Joanne DePietro, or Joan DePietro, asked, can you please provide some information on the patient consent process you follow, as well as the documentation within the medical record?
Great. Yeah, good question. So in the case of our OB visits, they're obtaining that consent at the OB intake visit. And there's some verbiage in our appointment reminder system that basically talks about the fact that this is going to be conducted via video. It's secure, HIPAA compliant, those kinds of things. In the patient documentation, or for the provider documentation of those encounters, we actually worked with our legal department and our compliance department to make sure that we had documentation that could be standard. So basically, we've created a smart phrase that a patient or a provider can just plug into the note for the patient, and depending on the mode of virtual care that's being used, they can choose a different smart phrase. And functionally, it talks about, I've talked to the patient, they know that it's via telemedicine, we've discussed the implications, and again, there's sort of a legal script around that. It's a short paragraph, and then the provider puts in I was located at, and then they would put in their clinical location, and then the patient was located at, and then the provider would put in where that patient is located. So as part of our training, we tell the provider that best practice, we want to collect the patient location. Obviously, we want to make sure that they're in a physical place where the provider is licensed, but we also want to make sure that they're safe. And if there's any sort of adverse event, we could send emergency services there. And then we want to collect the phone number in case there's any sort of technical issues so that the provider could get a hold of the patient if they needed to outside of the video.
Awesome. Very good. Thank you.
Mhm.
And then Gemma Lowry submitted the following question. Who determines what use cases receive the higher priority? And do you have some sort of steering or governance structure for that process? And can you provide some framework?
Yeah, actually we do have a virtual care steering committee. So we actually have fairly formalized our process where there's an application form, and we have to collect a certain, or I should say the use case, whatever group wants to do some form of virtual care, they have to go through not a super extensive application, but an application that really walks them through, what is the use case, how many patients, how many patients do you expect to use this, how many providers would like to provide this service, and just talking a little bit about the how. Even though they might not know exactly how it would work, we want them to envision how it would work in their workflow, and then have them really talk about how is it replacing an existing, or how is it different from an existing workflow and a more traditional in-person. And then once that application is received, it does go to a steering committee, and we're looking at things, or the steering committee is looking at things of, what's the impact? How many patients are we looking to serve? How many different departments or how many different providers are involved? What's the financial impact? And then I guess from a what makes sense standpoint, is this something that in the case of like our BCBAs, where we're offering this program where patients would either not do it or do it via video, and maybe we're driving volume. So there's a lot of different factors, and certainly we can maybe get more into that. I've got my email address at the end, so if there's maybe more specific questions that I can answer, I'd be happy to do that for you. But that's kind of high level. So there is a prioritization and an oversight committee that sits under our medical group and kind of directs the work that we do, since we are such a small department, and we have to be able to make sense and navigate what the next project or next projects will be.
Then one last question from me, Marie.
Mm-hmm.
The infamous question about billing. How are you guys, is it all being driven through your EMR? Are there some things that you've had to navigate specifically around some of these visits? I feel like maybe you guys have set the bar pretty high for some folks who maybe have not ventured down this path, or maybe that they're not, but maybe certain organizations aren't prepared to pay for these visits.
Sure.
So can you just share with us how you guys navigated that and what it looks like?
That would be about 10 webinars in of itself. But I guess the short answer is that we, from the very beginning, have partnered very, very closely with our revenue cycle team and folks who are looking at how the bills go out. And then we've also been able to partner very closely with certainly HAP, our Health Alliance Plan, who's our insurance arm, and talking with Blue Cross Blue Shield, which is which encompasses a lot of our patient population, as far as that's a main payer. So we're partnering with the insurance companies as much as possible. We're looking at obviously CMS and what they cover. We're doing a lot of communication around how certain things need to be billed, and then we have monthly metrics that we're looking at. So we are constantly looking at the individual programs, the CPT codes that are being used, and how they're being reimbursed or how they're not being reimbursed. Again, the programs that I mentioned as in the course of this webinar, we haven't gone the traditional billing route with these visits. And these programs, I don't want to say are easier, but they're a little bit easier because, again, anything that's sort of that global billing or that package billing where we don't have to worry about individual encounters, then that's something we don't need to worry about. We're functionally, for the OB visits, we're dropping a dummy code, and then we're looking at the overall course of care. So that's easier, and we don't have to worry about insurance in this case. And then with the autism, again, BCBAs are not approved telemedicine providers. So in theory, none of the insurance carriers are going to cover it. But knowing that, then we're looking at what are alternate routes. And so one of the alternate routes are that there are parents who are willing to pay out of pocket for this. So we've looked at what those codes look like, and those are retail codes that the providers are dropping in those instances, and they don't go to insurance. Or we've got a grant that's covering it. So again, those are specific codes that are not going to insurance. But in areas like primary care and some of our specialty services, it's definitely something we have to consider. And certainly patients who we know have coverage that will not cover telemedicine, then the organization, specifically the department, needs to determine how they want to handle those patients. In some cases, they decide that they'd still like to see them. In other cases, they determine that they're just not going to be appropriate for telemedicine as a mode of care. It's interesting, and billing is probably the biggest challenge and the biggest barrier for us as a health system in rolling this out, because we may have some great use cases, but billing is just a big challenge.
One last question from me, even though I said that the last question. When you guys did your rollout to your physicians, were you systematic about it, or did you, was it on a case-by-case basis that you did the rollout, or did you do a true physician rollout and then a true client rollout? And then I know we just have a few more minutes, so just want to make sure everybody's aware of Marie's contact information on the page right here. And thank Marie so very much for sharing her wisdom with us today. And now I'm going to be quiet and let Marie answer my question.
Sure. So we kind of took the initial approach. So we've been a formal department since around 2015. And in the beginning, it was very much provider driven. It was specific programs and providers that had an interest in providing virtual care. And when we started, it was actually a lot of clinic to clinic, where the patient was still coming in physically to a clinical location, but was connecting to maybe one of our specialists who was in a different area. So, for us, a lot of times we have patients who live in a suburban area and maybe a specialist that they need to see that's really physically located in the city of Detroit. And so that's sometimes a barrier because they didn't want to travel to Detroit. And again, some of our suburbs are pretty far out. So we started really on a case-by-case basis. As people were coming to us, we were developing those programs. And then the first product line that came to us as a department and said, we'd really like to roll this out to all of our providers, was internal medicine. And internal medicine said, I want all of our providers to be able to provide follow-up routine care to any of our patients through any of our medical centers. And so that was kind of our first rollout to providers. So we had some willing providers and some not so willing providers. And to this day, we've rolled out to a couple of hundred of our primary care, so internal medicine, family medicine, pediatrics. Probably about 25 to 30% of those providers have actually done a video visit, and then an even smaller percentage, probably like 5 to 10%, have actually really incorporated it into their practice and see patients for medication rechecks, anxiety and depression follow-ups, maybe ADHD rechecks. Sometimes it's blood sugar or diabetes compliance checks. So there's been really some folks that have embraced it and some that are still a little bit hesitant. So it's kind of been a hybrid. In most cases, it's people who are willing and interested, but in a few cases, from a product line standpoint, they decided that we want all of our providers to do this. Behavioral health was the next big, everybody should do or be able to do telemedicine or virtual care. So it's been a little bit of a hybrid.
Thank you, Marie. I really
Yeah.
appreciate it. We are officially right up against 2:59. Please remember that the National Consortium of Telehealth Resource Centers provides a webinar series on the third on the third Thursday of every month. Our telehealth topics certainly evolve. Our next date is going to be January the 16th, 2020. Hard to believe that the new year's so close upon us.
Amazing.
I know. Thank you so much to everybody who participated today. We certainly welcome all of the feedback that you can provide to us. Please don't forget to fill out the questionnaire and give us some feedback. And to each and every one of you, happy holidays, Merry Christmas, Happy Hanukkah, and blessings abound to everybody. So thank you, Marie.
And thank you everyone for your attention today. Appreciate it.